So Josh is as good at shepherding us as he was the expert panel. And when we talked about cases to discuss, we wanted to have some that would also maybe engage a group that was maybe a little bit more dominated by internists and perhaps pulmonologists. And so my task is to talk about a case that highlights a couple of more comorbidities that might be important for that group of practitioners. So this is Alex. He's a 19-year-old male with a history of asthma who's been dragged to CU by his parents because he's going to be going off to college the following month, and they're concerned about his asthma control. He tells you that he's currently using his rescue inhaler more than a couple times a week, occasionally daily if he has a cold or other triggers like seasonal allergies. He has a history of rhinitis as well that comes out. He has Flovent. He uses it twice a day. He's not sure of the dose, but he tends to use it a little bit more when he has more chronic symptoms, as many of our patients will. He's not been hospitalized since he was very young. He sort of tends to minimize the problem. You talk to him a little bit on his own without his parents appropriately, and he seems to sort of brush it off. He also admits to perhaps some exercise-induced symptoms. As past medical history reveals, the seasonal allergic rhinitis I mentioned, but also it comes out, although it wasn't prominent to the family when they came to see you, that he had a peanut allergy diagnosed when he was 4. It's been many years since he's had any accidental ingestion. His mother tells you that he used to have allergy to multiple foods, other foods as well, that he's outgrown. So his medications, again, albuterol, the Flovent. He has an EpiPen prescription. They think it's current. He doesn't really carry it very consistently. And he's planning to attend a big public university in the fall. He'll be dormed on campus with 2 roommates that he's just met on Facebook. So what do we think about this patient? The first thing I want to talk about a little bit is that history of peanut allergies. So if you're seeing him perhaps as a non-allergist in particular, a couple points I want to make about him. First of all, you've already heard from the other speakers, I think forcefully, that IgE doesn't equal diagnosis. And one thing to think about in someone who's had a lapse of many years of clinical reactivity is the possibility that, in fact, he might be in the subset of patients who outgrow their peanut allergy. So one reason to consider someone like this seeing an allergist if it's been a while may be, in fact, to sort of reassess his history, his diagnosis, et cetera. The other point, though, that unlike maybe the 19-year-old who has a history of seasonal allergic rhinitis that developed perhaps as a school-age child and has developed maybe some itchy mouth with peanut subsequent to that or coincident with that, this is a child who has an early history of peanut allergy. And one of the things we know about that is it does make it a little bit more likely that his sensitization is to allergens that are not related to aeroallergens like birch pollen, but more likely to be sensitized to allergens that are associated more strongly with systemic reactivity. So this brings us to this guideline 3.6, the risk factors for severity of allergic reactions to foods. The severity of allergic reactions to foods is multifactorial and variable. This is one of the things our patients often ask us is my child or am I at risk for anaphylaxis? Do I really have to carry my EpiPen? I've had a few reactions. I had hives. I had some vomiting. Maybe I had some nasal congestion, but I've never had full-blown anaphylaxis. Am I at risk? And unfortunately, we have no good test currently that stratifies those people or identifies with any real prognostic value individuals that are at greater risk. But we do know, picking up in the second sentence, that the severity of reaction is not dependent upon the severity of past reactions nor by the level of IgE. The factor most commonly identified with severe reactions is the coexistence of asthma. And so for this individual who has an early diagnosis of peanut allergy, therefore, while possibly outgrown and should be reassessed, is at greater risk for sensitization to those allergens that are associated with systemic reactivity, also has relatively poorly controlled asthma, and is going off to college not carrying his EpiPen. This is the kind of kid that multiple studies of fatal outcomes or near fatal events is the picture, is sort of the poster picture of. And he really needs a tune-up of his asthma. He needs reevaluation. of his peanut allergy. He needs to get the gospel about carrying his EpiPen. Asthma patients with food allergy are known to have more ED visits for asthma and are more likely to be hospitalized, whether this is a biomarker, so to speak, of worse asthma or because that's related to accidental ingestions is not clear. Children with sensitization to food allergens have been shown to experience a higher rate of hospitalization and steroid use, and self-reported food allergy is associated with a higher rate of hospitalization as well. So I would submit that the fact that he has coincident peanut allergies should also sort of highlight for you the importance of asthma management in this child, that despite his relatively benign history for the last few years, I should say this young adult, that he really needs attention to his asthma. So he goes off, he has a good fall semester, he comes back to see you over the winter holiday break, and he tells you that he's doing really well, he's using his inhaled corticosteroid, his asthma has been well controlled, he swears to you up and down that he's carrying his EpiPen, but he mentions to you that he had an unusual experience. He was having some steak at the dining hall, and he felt that a bite had become lodged in his throat for several minutes. He was concerned about it. He says that he could breathe okay. He didn't think it was really an allergic reaction. It was, he didn't have itching. He didn't have any other hives or other symptoms. He said it didn't feel like an asthma exacerbation. But it did prompt him to seek medical attention. He was on his way to the health office when it passed and apparently cleared. He was sore for a little while. And the only other thing that you get from history really is he says at baseline he does admit to some chronic substernal pain, and on pressing him a little bit, says that he has some mild dysphagia that's been going on for a few years, that he has the experience sometimes that foods have a hard time going down. And I could have presented this a little bit in a more severe fashion. Sometimes you'll see an adult like this who comes in actually with a frankenpaction and goes to the ED and ultimately has the food dislodged by endoscopy. And what will come back many times in these patients, if they do a biopsy of the esophagus, which increasingly gastroenterologists appreciate that impaction is a fairly specific indication for this entity, and they'll do it, is high levels of eosinophilia, usually very superficial eosinophilia in the esophageal mucosa. So what is eosinophilic esophagitis? So this is defined by a parallel consensus statement around the same time. Chris Leocuris is the lead author, and I refer you to that. Is an immune-mediated esophageal disease that's unresponsive to proton pump inhibitors and characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. So the endoscopy is the only accepted gold standard diagnostic test, and allergy evaluation is warranted. Why is that? Well, the expert panel weighs in on this question of what can the allergist do in the form of tests by saying that the expert panel suggests that skin tests, specific IgE tests, and ATP patch tests may be considered to help identify foods that are associated with EOE, but these tests alone are not sufficient to make the diagnosis of food allergy. The role of these tests in the diagnosis of other EGIDs, that's eosinophilic gastrointestinal disorders, has not been established. And if I had put up sort of the level of evidence, et cetera, and the weight of expert opinion, it would have been low and high. So EOE is, for many people, a food allergy, and I would argue from data that's come out of Chicago and other centers that even in the adult population, there are a significant percentage of individuals who will prove to be food responsive, and that is meeting the definition that Josh put up at the very beginning of the slide, with is an immune-mediated adverse reaction to a food. The question of testing for IgE or other test modalities here, including patch test, is a tricky one because studies have not been definitive in determining the predictive value of such testing for the relationship to a trigger food. And we have a problem in this case, not only of false positives, which is sort of common when doing IgE testing in individuals who also are often atopic, and about 2/3 of these individuals do have other evidence of atopy, as in our case. But they may also be falsely negative. And for example, in the case of milk allergen, the sensitivity of such testing is thought to be probably no better than 50%, no better than a coin toss. So really, this disease, a few points I think I want to make about it. It's a disease of both clinical symptomatology as well as pathology. I think you need to have both to have disease. The natural history remains at this point still very poorly defined, and therefore the questions of sort of how aggressive to be about its treatment are difficult to grapple with, but whether it's going to be the use of swallowed steroid, which has been shown to have good efficacy, or the use of elimination diets, which also have efficacy, is made more problematic by the lack of understanding of that natural history. The expert panel has two guidelines with respect to how to manage this that include or touch on EOE with some overlap. So the effects of dietary avoidance on associated and comorbid conditions such as atopic derm, asthma, and eosinophilic esophagitis. Guideline 21, in individuals with documented or proven food allergy who also have one or more of the following, which includes EOE, the expert panel recommends avoidance of their specific allergen or allergens. So if you can identify the allergen trigger, it's the expert panel's recommendation that you offer the patient that as a first-line management or treatment. Guideline 22, for these same individuals, without documented or proven food allergy, the expert panel does not recommend avoiding potentially allergenic foods as a mean of managing these diseases. And I highlight this because I think probably all of the allergists in the room have had the experience of seeing patients who are on extensive and prolonged elimination diets without gold standard evidence that those foods are associated with their disease, whether it's EOE or atopic dermatitis. And so I think what the expert panel is urging us here toward, and what I strongly agree with, is the need for either getting definitive diagnostic resolution or finding other alternatives. And that's what I have in terms of formal slides.
So I'm now going to ask our panelists to come up and have a seat and take questions and comments from the audience. So I will take the prerogative of the moderator and ask the first question of Dr. Shreffler. Can you tell us what you would consider to be definitive causal evidence of a food and eosinophilic esophagitis?
So I'd say the definitive answer is reproducible tissue eosinophilia with symptoms provoked by that food. Now, obviously, this is a difficult standard to meet often, and so in clinical practice, what I and I think many allergists working closely with gastroenterologists will do is, if for the patient who is motivated to determine whether or not their eosinophilic esophagitis is a manifestation of food allergy, is first start on an elimination diet. I usually advocate for that being relatively broader rather than starting off with just single food, because I think you maximize the chance of getting a definitive yes or no up front. Is this a food allergy or not? I also think it's psychologically difficult to having failed to show efficacy of a single food, then contemplate avoiding more foods. And lastly, I think since we know that for a subset of patients it will prove to be more than one food antigen, rotating from one to the next is usually a recipe for disaster. So a relatively broader diet for those patients who are motivated, and then demonstration of symptomatic and pathologic clearance, followed then by reintroductions of foods. And here there's some art and there's some balance to be found, I think, between multiple biopsies, which are the gold standard for diagnosis, and just the reality of wanting to avoid invasive procedures repetitively. So we'll often introduce 2 or 3 foods, usually stratify them by risk, both in terms of those foods that are found to be most prevalent for EOE, like milk, as well as using the tests as some indication when they're positive that perhaps that's a sign that the immune system has made an untowered response, and then repeat biopsies then after every few. So it's not a short answer.
Dr. Sloan, was your hand up, or are you just trying to be chill?
I'll do both, but I'll fail at the chill part. I'm asked almost weekly about advances in attempts at food desensitization, and I've been hard-pressed to find any reliable, believable data that it is safe to even attempt this. Can you just opine on that?
The question has to do with whether food desensitization is feasible and safe.
I think that really food desensitization is a research protocol now. I think that there's still a lot that needs to be done to understand the best way to do it, the amount to use, which patients are the best candidates. I think there's still the question of, is the risk that you take doing the desensitization warranted in comparison to avoidance? So that's my thoughts. I think, I don't know if Wayne or Mike want to.
Yeah, I mean, I would reiterate it. We're seeing more and more patients not only ask, but in some cases find providers, sometimes alternative providers, who are offering desensitizations. The expert panel commented on that specifically, saying in 2010 that it was still in the research arena. I feel strongly the same. I get accused or feel at least vulnerable to the accusation that we're biased. We have a biased opinion. I'm doing currently a peanut OIT study. We have NIAID funding to do another. But I think all the points Lynda raised about still big questions regarding who are the patients that are most likely to benefit, the long-term safety, are important questions that have to be addressed, I think, rigorously, and we will lose the window of opportunity to do that if this becomes some sort of quasi-evidence-based practice.
The irony of this is that the question of whether one should do desensitization to food was one of the recommendations that had the strongest evidence in support.
Right. But that evidence really is almost entirely desensitization, taking it every day, protection from accidental reactions.
Right.
And in data shared by Wesley Burke's group at the Quad AI a couple weeks ago, I thought it was very interesting that it looked like only about 40% after a median of something like 4 years achieved something like true tolerance, in other words, ad lib tolerance of peanut. So we obviously need to do better than that.
Dr. Arm, you had a question?
No, Dr. Science, what was out of my mouth?
As usual.
As usual.
Yeah. Take a question from the Mass General group.
Patients that had food protein-induced colitis as an infant, for instance, and development of eosinophilic esophagitis later on? And if so, is it often the same food that caused both problems?
Yeah, so I'll just repeat the question, which was, is there any known association between allergic colitis in infancy and subsequent development of eosinophilic esophagitis, or I think we could broaden it to eosinophilic gastrointestinal disease in general, and not to my knowledge, and it's actually an area that we're interested in researching. Anecdotally, we seem to, I don't know, maybe you guys can comment as well, I've seen patients who have an early history of some form of intolerance and sometimes more definitively evidence of colitis that present with EOE, but obviously that's just anecdotal.
Yeah, in my experience clinically, most patients who have these disorders who outgrow them, over time, I don't think there's been any increase in GI symptoms subsequently.
Any other questions? If not, I want to thank our three panelists for a wonderful presentation. Thank you.